I'd like to thank you all for letting me presenting in this wonderful conference. Our case today is all about calcium in coronary intervention, and it was a case with disastrous complication, and we'll see what happened. I chose this name because of the feeling I felt while we were operating on this case. Calcium at most of times will be the worst enemy for coronary interventionists. Short history of our patient. He's a 55-year-old male patient, smoker, and works as a driver. He's known to be diabetic for 10 years on oral hypoglycemics. He had previous PCI to CIRC with the drug-eluting stent 2 years ago. And he was presented to our office by a recent acute coronary syndrome, to our ER actually, for which he was admitted in the CCU. The patient was oriented to time, place, and person. Heart rate was 87 beats per minute, and blood pressure was okay. Respiratory rate 15 per minute, and chest examination showed harsh vesicular breathing, and apical S4 was noticed. His EKG showed anterior T-wave inversion, and the echocardiography normal LV dimensions and fair LV function. It was 50% by modified Simpson's method with hypokinetic basal and mid-anterior wall and basal septum, mild mitral regurgitation, and sclerotic aortic valve with no significant gradients, normal right side. He was planned for an invasive strategy. This was his angiography. The LED showed just after the ostium subtotal occlusion with another lesion afterwards, and the stent in the CIRC appeared patent with no problems. Also, the ostium of the diagonal was somewhat affected. The mid and distal LED was diseased, but with no significant lesions. And this shows the second lesion in the LED. Okay, again the lateral view. And the right coronary was also atherosclerotic with no significant lesions requiring revascularization. Till this point, everything went smooth. We passed our wire. We were deceived somewhat by the amount of calcium. It didn't appear very well in the angiography, as you can see. So we proceeded as an ordinary case with wiring the LED, and then we tried to pass the stent. Maybe at this point we should have pre-dilated better, but we tried to pass the stent at first, and then the problem happened. It was really a nightmare. The stent was unmounted from the balloon, so we tried to pull it out, but a more complicated problem happened while we are pulling it out. It stripped, and she was stuck in the calcium. Then, by gentle pulling, she was unmounted from the calcium and entered in the aorta, but it was stripped, and we went down till the femoral artery, when it totally separated and was floating in the femoral. This was the view. When it went into the common iliac, we didn't find any solution except that we should snare it. And actually, this was my first time to use the snare in pulling a dislodged stent. But we didn't have any other options. So we used the snare, and we went from the left side. From the right side, we cannot retrieve it. We went from the left side and used the snare to get the stripped stent out. You can see it going out, and we could not retrieve it completely inside the catheter, but we pulled it like as you see. This is the last step of pulling it out from the femoral artery. She was somewhat stuck, so we feared that a piece of it was maybe torn or left residual part in the femorals. So after we pulled it out successfully, and after pulling it out, and this is the last step after we pulled it somewhat outside the skin. Then we made sure that no pieces were left residually by imaging of both iliac regions. This is the right side with no residuals in it, and the left side also. We scanned all the area to make sure that there is no residual found inside the femorals or the iliacs, and it was really clear. We retrieved it completely outside the body, but was completely stripped, but it was not torn. So after this completed successfully, we were thinking about should we complete the PCI to the patient or stop at this point and reoperate again after some time. But we were courageous enough because the patient was hemodynamically stable and no problems happened after this point. So we re-entered the LAD again and did the PCI because he was in non-STEMI, and we didn't want to let him wait. Maybe the problem will progress more in the LAD. So we re-entered the LAD again, and we pre-dilated the lesions very properly. This is the first lesion, and then we dilated also the second lesion to facilitate the passage of the stent. Then we put a long stent to cover both lesions. We didn't protrude into the left main because we had the landing zone that was possible to put the stent in. Then we inflated the stent at this position, and that was the final result of the LAD with no problems and TIMI-3 flow. Maybe the take-home message that we should never underestimate calcium in the coronaries, but the problem is sometimes we cannot see it. It's more properly assessed surely with IVUS. With the ordinary angiography, we cannot assess the amount of calcium, so we can be deceived by the normal appearance, and we can progress with the trial of direct stenting or passage of the stent, but sometimes it turns into a true nightmare like what happened with us. But fortunately, this case went smooth, and the patient was discharged successfully with follow-up of with no symptoms, and he's doing well till now. Thank you.
Thank you for presenting that. That's Zasan. You're going to learn a lot from this case, and thank you for coming up there and presenting this complication, which in the end looked great. That was a wonderful result. I get the one thing is, and you hit it, is preparing the vessel before you even start. I think is key, because I've been burned many times, unfortunately. Even when you think it might be a soft plaque, when I see something that's that stenotic, I lean towards just pre-dilating, just not so I can deliver a stent, just to make sure that it will expand. Because you don't, even if you get your stent in there, if it's crushed like a dog bone, or you can increase your stent thrombosis and your restenosis. But that was a good bailout, how you pull that out. I've had a stent that actually got dislodged too, and in the first place I look at it up towards the head, make sure it's not in the brain, and then I take a sigh of relief. I'm like, thank God. And most of the cases I know, they typically fall to the lower extremities, and another thing you can do if you can't snare it out, which is great to get out of the body, is you could try to crush it, wire the extremity, and then get a balloon and either try to crush it or even try to pass a wire through, which is probably very difficult, but that's another bailout.
I'm curious, what was the mechanism? What do you think the mechanism of the stent stripping was, and what did the stent strip on? Did it strip on the calcium? Did it strip on the guide when you were trying to get it back into the stent or into the guide?
No, from the calcium. The calcium sometimes has sharp edges. The sharp edges can strip the stent off, and this is what happened in this case.
And where did the stent originally get dislodged? What was the location of it? Was it in the
from the proximal LAD?
In the proximal LAD. Okay.
From the proximal lesion.
So having stripped too many stents in my career and gone to many complication courses where we see this happen. Oftentimes the easiest thing to do is to deploy it or to crush it where it's at. We've found that the more that you do to try to get it out, sometimes you introduce new and more complications. I'm curious, if it's stripped in the proximal LAD, how did that end up in the femoral? Did you snare it in the coronary?
No, I pulled it out with the wire and the guiding till the femoral. Then it completely separated off inside the aorta, and it descended into the femorals.
Okay.
So you were able to maintain it on the wire,
Yeah.
and pull it back without putting
Yeah.
a second wire down, or
No.
anything?
Inside the coronaries, yeah, it was maintained on the wire till we were back in the aorta. Then it's stripped off. It completely separated there.
Yeah, so I think, as Jason's saying, this happens. You should know there are ways to address it. Just deploying it where it is probably the easiest thing to do. If it's off the balloon, sometimes you can get a small balloon through it.
Yes.
And slowly serially dilate it and deploy it there, crush it. You can put a second wire next to it, unravel the wires together, pull them both back into the guide. And then in terms of your extraction from the femoral, was that just through that didn't look like a sheath that was in there?
No, directly the catheter with the snare.
Okay, so
Yeah.
you had,
Without a sheath, no. I
Okay.
entered from the left side.
Yeah.
I couldn't retrieve it from the right side where we were introducing our sheath.
uh-huh.
So we entered from the left side, and I entered directly with the catheter with the snare inside it without a sheath.
And it looked like just a loop snare, is that?
Sorry?
A loop snare?
Yeah, it looped snare. Yeah.
Hey, the difficult thing with this is you got stuck in a very, very tight lesion in the prox LAD, so you have probably no chance of deploying it there because you're not going to deploy it.
The problem was
Yeah.
that it's stripped
Yeah.
off. The stripping
Yeah.
will make the deploying it very difficult. If it was still in an integrity position, we can do it. But
Yeah.
if it's stripped, I think the better to be pulled out.
I'm not sure it would have expanded though if you deployed it. If it was that calcified in your prox LAD.
Yeah, and then part of it was in the left main.
Yeah.
So
yeah,
it will be a problem if you didn't crush properly.
yeah. That's good.